Thank you, Chairwoman Collins. Thanks to all of you for your expertise during this very unprecedented time. I first want to echo, I'm a co-sponsor of Rick Scott's bill that's focused on testing and ensuring that people can get free testing during this once in a century pandemic. And insurance companies are not denying that to people, or there's a financial burden. Hopefully that's something that everybody can agree upon, and we need to get that passed. We should just not have finances be a barrier for people getting tested. I want to talk about the impact of the coronavirus on Native American communities. And as you've all mentioned, underlying health conditions such as diabetes, we know is one of the strongest risk factors for COVID-19. We also know diabetes is far more prevalent in minority communities, and we have 22 Native American tribes in Arizona. They have a greater chance of having type 2 diabetes than any other population. In fact, in Arizona, the Gila River Indian community has the highest rate of type 2 diabetes in the world. So Congress has established the Special Diabetes Program for Indians, the Sdpi, in 1997 to provide funds for diabetes prevention and treatment services. Through the Sdpi grant program, tribal communities have been able to develop much needed diabetes programs and increase access to quality diabetic care. While this is very popular and effective, it suffered from short-term reauthorizations and stagnant funding, which is why I introduced legislation along with my colleague from Arizona, Senator Sinema, to reauthorize the Special Diabetes Program for Indians for an additional 5 years and increase the funding to $200 million per year. Dr. Karnathan, in the midst of the pandemic, where there's multitude of obviously healthcare funding priorities, can you talk about the importance of maintaining focus and treatment for underlying conditions like diabetes and the importance of programs like the Sdpi?
Absolutely. Thank you so much for bringing up this important point. Pre-COVID, I spent most of my time on diabetes, cardiovascular disease, and lung disease. And these conditions are not going away, and these are the conditions that are leading to these adverse health outcomes from COVID-19 exposures. One thing that is not going to happen is that COVID is not going to magically go away. We are going to be living with COVID for a long period of time, and there's no indication that the underlying health conditions are going to become less problematic for people who are exposed to COVID. Using that rationale, we need to continue to support research that prevents the development of chronic diseases such as diabetes, hypertension, chronic kidney disease, heart disease, that are predisposing to worse outcomes. We need to provide strategies for managing those conditions. In my testimony, I mentioned the use of telehealth and telemedicine, particularly via video. I think this is critical because older adults may find themselves skipping their maintenance visits. And the opportunity to be on a call, or better yet, a video call with their physicians to make sure that they are managing their chronic conditions is going to be critical throughout this so that we can protect them from developing the worst outcomes. And so I think the work that you have done so far to provide support for these resources, particularly in Native communities who are suffering mightily, definitely needs to continue.
Thanks, Dr. Karnathan. That actually brings up a follow-on for me. I have legislation with Senator Doug Jones, also on this committee, about medical monitoring, especially for rural communities. So it's not just the telehealth, but it's the actual medical monitoring. If you have continuous glucose monitoring and things like that, you can transmit that information without having to take transportation long distances to get to the doctor. So how important is the medical monitoring as well as the telehealth?
I think the medical monitoring is critical, and you bring this up at a time when we're working to adapt our research programs to use Bluetooth-enabled devices so that we can have blood pressure measurements sent regularly to physicians, glucose monitors sent regularly to treating physicians and clinicians so that we can monitor. I mean, it has always been a wonderful strategy for those in rural areas or far away from healthcare providers to be able to track more regularly. And these are critical things that need to happen. But in addition to making the technology available, if you build it, they will come isn't enough. We need to leverage people who can go out and teach older adults and our adults to use it. I've done a number of Zoom explanations with my family members, and I know that, you know, people need help with these technologies and even how to set them up. But all of that is really critical to making sure that we can keep the population as healthy as possible.
Great, thanks. Madam Chair, before I forget, the Navajo Nation has submitted a statement on the COVID-19 impacts for Navajo elders in particular. I would like to submit this to the record.
Without objection.
Thank you. I want to shift to Arizona has a growing Hispanic population. According to the American Psychological Association and National Survey, looked at people 70 years of older, 44% of Latinos received home-based family caregivers compared to 25% of non-Hispanic whites. And ethnic differences were found among those with regard to the care recipient. Among those age 70 and older who require care, whites were more likely to receive help from spouses compared to Hispanics, more likely to receive help from their adult children. The instance of the adult children being caregivers more likely for the Hispanic population, we know anyone who is a caregiver, you're also taking time off from your job to care for your loved one. That impacts your livelihood and support for your own family. So Dr. Mack, can you talk about just these issues with caregivers specifically? What other challenges do minority caregivers face and preventative measures we can take to ensure the protection of both the caregivers and the elderly?
Yes, thank you. Minority caregivers tend to, of course, have less resources. As you know, unemployment is usually higher in those communities, less time to take off work. And oftentimes the kids are engaged and sometimes the children are actually missing school. So I think this goes into more resources to not only care for the populations in a preventative manner to make sure that they don't get sick, but also have those tools such as telehealth, et cetera. But also those social programs that help support families, whether it's around meals or whether it's around caregivers. As you know, today, if you are elderly and the ability to actually go into a nursing home, I have people in my family have Alzheimer's disease. People had to retire early and they're looking for resources because the insurance does not pay, or we don't have any way to pay for them to put them in a personal care home. So I think, again, we've talked about those social determinants, and the healthcare system itself can't take care of everything. We have to put resources in those areas of prevention, but that are outside the walls of the facilities to support these families from not only healthcare services, but also social services, that the kids can continue to be educated and et cetera. And let me just say this, the Wi-Fi gap, they call the homework gap, is also the telehealth gap. So the same folks who can't get the homework, especially during this time, and they're gonna fall behind. And education is an indicator of health.
Wonderful, thank you. Thank you, Madam Chair, for having this hearing.
Thank you. Senator